evening once again, and welcome to Doctor and Call for another Tuesday evening. It is the 19th of November 2024, and we are pleased to have you with us. Of course, all our listeners, our friends on GBN Television Channel 7 and 11, also our friends on our Facebook page and YouTube channel, and our listeners on K105 FM. We thank you for joining us. And of course, as always, I hope to share information with you this evening as it relates to your wellness. Well, our wellness, as we always do. Dr. Nixon is with us as usual, and also joining us this evening, Dr. Fraser. And he's no stranger to the program. He's been here before. And tonight we continue our discussion on diabetes. It is Diabetes Month, Awareness Month, and also with some emphasis on our men folk. It's International Men's Day today, so we would put some emphasis there, also paying attention to the impact that the heavy showers and flooding is having on our ability to access health care and other things we need. So once again, thank you very much, and we look forward to chatting with you a little later on in the program. It's a good time to welcome our guests, and we'll start with Dr. Nixon. We'll leave Dr. Fraser for last since he's our special guest. Doc, good evening and welcome to the program again.
Well, good evening, Godfrey. I'm happy that you got home before this week. Last week you were leaving with trepidation and having to wait and let Elijah bless help you cross the river and all of them kind of things.
Yes,
I'm glad
indeed.
you got home safely, and I'm glad that most of us have done well. I want to extend condolences to the family who lost their wife and mother, daughter, cousin, whatever it is. It's really, really, really a very sad thing for me. Something happened so soon, and kind of reminded of what happened in Spain. We talked about last week, right? Sudden delusion. People are affected so severely. So condolences to this family. I hope they find peace, and may the lady rest in peace, Mrs. Frank.
Yes.
It's really, really very sad for us. We haven't had that kind of experience, with rain for a couple of hours and then it's total chaos.
Yep.
I'm a little more concerned also about our children, for whom that was a big disaster type experience. The children who had to run for their lives basically because of rising water. It's very impactful, and childhood trauma can bring a lot of negative impact on adults later in their life. They don't understand why, but because of trauma they experienced in childhood. I'm glad none of our children was affected, but I think it's something we need to keep our eyes on as to how our kids would respond, having experienced such a disastrous event, is what I think.
Yes. And
I want to welcome that group of people who listen to us every week. There's a set of seniors on this island who listen to our program every week. And tonight I want to extend a special welcome to them, especially the men folk whom we're celebrating today. Those men who take life and family and occupation and development of community and nation building and all of those things seriously, and who have their lives very profoundly rooted in whatever spiritual being, good spirit I mean, okay? Whatever spiritual being they respond to. So happy International Men's Day, or greetings, special greetings and respect to our men on International Men's Day. It's not something that we really, really talk about a lot, and today we had a lot of other things we were talking about, but that does not mean that our men are less important. In fact, they are. We still live in a patriarchal society where we expect men to lead. And so we must support our men to make them lead. We must support our boys and tell them that it can be the best things in the world, so that they will, in fact, be the best things.
Yeah.
We must support our boys when we see them falling on the wayside.
Right. So it's a good time also to welcome our special guest, Dr. Fraser. Good evening, and welcome to Doctor and Call again for the second time. It's a pleasure to have you.
Yes, good afternoon. It's a pleasure to be here. I'm very delighted. And, we are going through a little phase, in the country with the weather patterns and so that started since last week. But God is good. Despite the challenges, despite the deaths, and so we pray that God will be the families that are mourning their loss. Also, World Diabetes Month for November. That's very important, and I think it's something that we ought to try to keep the awareness up outside of November as well. And well, happy International Men's Day to all the men out there, to myself, and all of us
Yes.
that we are striving in society and trying to make society a better place.
Yes.
And
Yes.
I just was giving Dr. Nixon, a little old talk. I was saying, well, we could have just do one screen because she's just next door
Oh.
to me. But
All right. Oh, yes. 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 Yes.
Yeah, we actually neighbors. So I don't know why he's saying good afternoon, but it's night, and it's been night for a couple hours, but it's all right.
Yeah.
you know,
So yes, indeed, it's always a pleasure, when we get together to have these discussions, and as you said, Dr. Fraser, we need to continue the awareness outside of just November, because diabetes is such a very, very serious condition, and even more so when we see many of our young people, teenagers, coming down with that condition. So, Dr. Nixon, I wanna start with you. With the discussion this evening, and I want to start first with our men folk. Now, it's International Men's Day, and we understand the role that we play, a very important one. And so we also know that there are lots of men who do have the condition, diabetes, and we know what can happen, where we can go if, attention or serious attention is not given to it. I want to ask this upfront as it relates to men and diabetes. Is there anything different? Let's say from a gender perspective, is there a higher incidence of diabetes in men than women?
No, actually, women have more diabetes than men.
Okay.
So the incidence of diabetes. I think what makes it worse for our men is that they probably will be diagnosed a little later,
Mm-hmm.
because the men aren't as committed to their health and lifestyle. They drink a lot. They drink more alcohol, and alcohol on its own. You know what it takes to make alcohol, right? Sugar cane, right?
Mm-hmm.
And if it's not sugar cane, it's derivatives, something that come out of that is sweet. So alcohol on its own is sugar, right? So men consume a lot more alcohol. They seek out health care later, and even if they're diagnosed, our men are not as adherent. They don't stick to it as much as the females do in relation to, getting their care, going to the doctor regularly. Sometimes I know my patients probably complain, but that's okay. They do it. I explain to them, like, look, you need to do things. There's some things they're going to need to do. You're going to spend a little bit of money more than you want to spend now, but let's get this thing, because I can tell you, my impression of diabetes is a galloping horse. If you don't put that last one and rein it in early and develop habits that makes it calm down and gives you control over it, it's going to run away. It is going to run away and do a lot of damage while it's running away. It's going to mash up your cabbage patch. It's going to destroy everything that you have. That's what diabetes is. And that is the challenge with our men.
Right.
Our men don't handle disabilities very well, right? But it also would be affected by the blindness and by the strokes and by the heart attacks and by the kidney failure and by the limb loss. And we see a lot of our men. I see so many men these days, a little bolder, who come out on the street with their crutches, right? The limb loss is more severe and more severe, because you might end up having a whole limb loss, or might have two toes. But there is lots of limb loss, which is something that can be prevented even when you have diabetes, even when you start to see changes. But it's something that should be prevented and should be thought of in the beginning. If only we'd adhere, we'd stick on to the directions and that are given by your healthcare team. If we would do what is required and don't find it so tedious. The truth is, I don't like to quarrel with the men all the time, because I think also we recognize that that's men's behavior. And that's not just men's behavior only in Grenada. That's men's behavior everywhere you go. They're not as health-seeking as women are. And so as families, as wives, as mothers, as, sisters, whoever it is, children, whatever we are, brothers, we need to encourage our men to seek out healthcare very early and preventive. And maybe sometimes we have to start teaching in our schools, getting our boys to be equally attentive to their healthcare, to their health as others. The other thing is that we tend to make boys feel, yeah, big boy, you can handle that. He fall on the bruises his knee. You don't have to baby him or feel that you're emasculating him, but you can say, let me see this. Let's make sure there's no stones in it. You understand? Let's make sure that there's no dirt. Let's just go wash it. Let's make sure it's clean. Did you wash it this morning? Did you put back on the Band-Aid? Those kind of stuff. So they become aware that whatever happens, your body needs to be cared. But if you say, boy, go on, please. You could look a bruise on you and you're a big boy like, what you crying? But stop. That's not what we need to do. We need to make them know, okay, let's stop. Let's see what's going on here. And so other healthy behaviors will come into play.
So it puts them in a habit of paying attention to things when it happens.
That their body's well-being is important.
Right.
Let's when you get a vaccine, don't worry. I know you're scared. Boys are scared because they don't do things like that. No, come inside, you'll manage. Don't worry. But keep encouraging, and women, keep encouraging our men to go get screened and to go to the clinic, till they get accustomed, because they do develop habits. There are young men who I'm very impressed with. No, I'm going to do my check. I need to do my check. My father died of X. My father died of Y. So, we really need to encourage. And my issue with the thing with the Bible. Every week we use the same Bible. We have to keep using it and using it to reinforce the message.
Dr. Fraser, come in here. You listened to Dr. Nixon regarding the issue of diabetes in men. Your comments on that?
Well, I do certainly agree on what she said. The thing is, the statistics will show, yes, women, like the higher rate of women, and that's because the women will visit the doctors more regularly. The women, go to their clinics and do their follow-ups and so forth. Unfortunately, us men, we have that culture of reservation. Then we would see things happening, symptoms, and then a lot of the times, you wait until a deathbed, unfortunately, before you go to seek help. And unfortunately, it's late, complications are way advanced. And, the lifestyle as well, that contributes a lot towards the detriment. For example, I'm just move a little to, for example, prostate cancer, right? Talking about men. And a lot of men, based on their family history and so forth, they are high risk, but they never went to check since their early 40s or so. And coming on late in the 50s, 60s, when they catch up the signs and symptoms of prostate cancer, it's already be advanced. And, there are little things that can be done, and the quality of life, are affected. With diabetes, we have to think about men on a whole. Sometimes we try to have that cover, being strong, but a lot of the times deep down inside, you're depressed or you're ashamed or you don't want to go and hear what the doctor or the professional would have to say, and, you will feel embarrassed and those stuff. And that too bring us back even to mental health with men, and building a certain culture of, self-care,
Dr. Nixon, diabetes is such a serious issue, and we all should be concerned because we know how quickly it can get out of hand, and probably one may not even realize that they're diabetic until it gets to a point where it's probably almost irreversible. When should one check to see if they have diabetes? Is there a particular time when, I should get up and say, you know what, I'm in my 30s now, maybe I should go see the doctor, have a test done to see if I'm diabetic?
So the challenge here is that not when. One should always be aware that diabetes is a challenge to us, okay? We should always be aware that diabetes is a challenge that exists because it's talked about every day, all right? However, if you know that you have family who is diabetic, if you know, even sometimes just have friends. So the earlier we can check, the better. We have so many health fairs in Grenada that nobody should lose the opportunity to get screened. Plus we have 30-something health facilities where you can walk in and say, I'd like to have my sugar checked, all right? If you have juvenile diabetes, and I'm sure Dr. Fraser can expound on that significantly, you'll probably be diagnosed from childhood, so that's a part. But what we call type 2 diabetes, adult onset diabetes, may come with symptoms or may not early. So some people will be told you have pre-diabetes and all that. I believe all of that is diabetes anyway. The truth is, I think the earlier you can, I would say at least 30, 25, 30, and maybe 25, because now remember we're talking about how, because of our lifestyle, and we mentioned childhood obesity and stuff, how much earlier we see diabetes manifesting itself, adult onset diabetes, even in adolescence. So it would be good if we can check. I would say 25 and for adults. I think that's a good age. To start screening regularly every year, right? If you have suspicion, you checked. But we have, I think each community has to gauge according to, we're still probably doing 13% of our population. So 13 people in every 100 may have diabetes, okay? Is likely to have. There are other populations in our region that is much higher than that, right? So depends on how the national statistics go. We might be inclined. I don't know that the ministry has any number that it says, and maybe it should, considering the situation we have, so we can identify earlier. But I would say certainly at 25. And if you have challenges with childhood obesity and stuff, we can check our children's sugar.
Right.
We have.
I was gonna go there because I remember in some previous programs, especially when we were talking about sickle cells, I know you did mention that even at birth, this is something that is also checked, to ensure that people are okay. The fact that we are seeing
sickle cell is a genetic disease,
right? Yeah.
So you either have it or don't.
Right.
Diabetes will develop at some stage.
Right. No. So I'm making the point here that the fact that we are now seeing diabetics even in teenage years, should we get to a point, and lifestyle is very important, the food we eat, all of these things, should we make it sort of almost mandatory that at the point where a mother is about to give birth, that the necessary checks are done to ensure that all is well?
No, well, in pregnancy, certainly you have to screen women for glucose and urine for their sugar level, because there is a condition called gestational diabetes. Women who during pregnancy have high sugar levels, and that does affect their children. Before we thought that the children didn't have any problems. Now we're seeing children that are products of that were in the fetal stage while with their mother being having diabetes, or having been developed in a mother with gestational diabetes. We see that they have a higher risk of developing diabetes down the road. Not necessarily juvenile diabetes, but just having diabetes at all. And what we know is that the women who have had gestational diabetes have an increased risk of developing diabetes down the road. So they need to be screened. And of course, most women are relatively young when they're pregnant. So you can't really want to go to that. I was going to say something, but it slipped me. It'll come back.
So, Dr. Fraser, you can come in here regarding the issue of probably checking very early, just to make sure.
Okay, so for me, I think we can check the younger one. So some years ago, when the Grenada Diabetes Association and other organizations would do, let's say, screening, we would do more of the workplaces and so forth. But because of the increase in the number of cases of children developing diabetes type 1, both type 1, type 2, being more concerning, there is an increase in screening at the schools. Where I studied in Cuba, so for example, everyone, like even if you don't have any illness or so forth, you are ought to do a checkup once a year at least. Once a year, depending on the condition, twice a year. So you are gauged. So according to the condition, you must do a checkup once a year. According to what you have, you do it twice, 3 times a year. Follow up with your general doctor. So I think even if we don't have a program like that in Grenada, but let's say if one decides from a parent with their children, they say, listen, every year I'm going by my pediatrician to check out my child just to see if everything is okay. I check out myself as well. I go by the clinic or whoever to do my regular checks. I think if we have that in the culture, right? Also, we have lots of health fairs, as Doctor indicated. Right now, you have health fairs left, right, and center. This is World Diabetes Month. There are lots of health fairs. Even before that, there have been lots of health fairs throughout the year by churches and different organizations. And persons could have gone to, just to check. Also, at the hospital, for example, you come in for, say, a cough, a cold, or, any illness or whatever. There's a general screen that is done. So they will check your blood sugar. Let's say you're going to be admitted or so. Everyone that's been admitted, their blood sugar is being checked. So even at that stage, there is screening. So sometimes persons come in and they come in for something totally different. But when they check the blood sugars are elevated, we do the necessary investigation to confirm and so and see what's the way forward. But I think if we have that general consensus of how are we going to check ourselves from since young, 25 years, I would agree, but I think starting before would be very important.
Right.
Even if there are symptoms or not, in that.
So Godfrey.
And especially, Doc, when we look at the diet of our young people, a lot of what they consume, the sweet biscuits and the chubby and all of these things, high sugar foods.
My favorite thing.
So and so it's on that premise.
I want to make a point. What I forgot. So one of the things we haven't had established and practicing is an adolescent health program. Adolescence is from 10 to 19. Okay, that's what we consider. We in Grenada consider our adolescent population. Right? If we had, because there's recently been an accepted adolescent health policy, which focuses on preventative care, primary care, and that will obviously be a component once the standards, because you have to have standards, you have to have programs that are written into this policy, right? This is what it's going to be. These are going to be requirements for screening. These are going to be requirements for how we treat XYZ, right? How we prevent ABC. So we know that our vaccine program goes like that. So every adolescent at 12 should have had their booster tetanus. Do you understand what I'm saying? Those things will be standardized practice. It will also mean that based on what our history is, how we see our demographics in relation to disease distributed, we can decide what goes on in there. And since we've been seeing children 13, 14, 15 with adult onset diabetes, it behoves us to make sure that that is one of the things that is included in a health visit. But what we have to do is to standardize how the visits are done. And Dr. Fraser mentioned what happens every year. I can tell you, in Jamaica, for example, right? Jamaica has a population of 2.8 million people, okay? Guess what? You cannot go to school unless you have a health screen in the summer. And there's a standardized form. You cannot, whether it's preschool, ABC school, primary school, high school, tertiary education, everybody has to have had a check and certain things looked for, right? And depending on the risk that the person runs, that it is what needs to be done is done, right? When you treat for worms, whether you look for blood and stool, whether they're going to screen for whatever, it has to be done. So what we need to have is standardized practices as to how we're going to look at the health and well-being of a younger population. But I can tell you, currently we don't have an age at which we screen people. And guess what? For diabetes. And you go and get screened if you feel like it's a voluntary thing. And I mean, that's your right, okay? But you also have a right. There's a responsibility from the health sector to ensure that people are screened for X, Y, and Z. It's just that we have not come together and married. When we're going to start, who we're going to start on, who are the priorities. We know that, for example, in Screening with Sickle Cell Association, that we were doing it, neonatal screening, not so much now because that program has ended and hopefully can be reinstated soon. But we know that all babies are screened. And then we know that if you're screened and you're negative, you're negative. If you don't have sickle cell, you just don't have it. The screener will tell you yes or no. Mm-hmm. And then if it's yes, it's going to be yes, you have the full-blown disease or you just have the trait, right? So the full-blown disease children know there's a clinic to which they go every so often, right? And then now we're trying to capture the people who have the adults with sickle cell disease. Most women will know when they're pregnant because you screen women for sickle cell disease, right? During pregnancy. So if a woman has full-blown disease or an adult, men come to screening when we have health fairs. They know that they can be followed up in that clinic. Those are the standards I'm talking about. Established systems, standards of practice. What does a child with sickle cell need? He needs to have his pneumonia shot every year. He needs to be advised about his diet. He needs to be checked for his blood count. He needs to be given advice as to how to stay well. Do you understand me? Those are standards of practice. But we don't have, in the case of diabetes, when do we screen? Who do we screen? Blah, blah, blah. Mm-hmm. We don't have that. So it's a question of establishing standards, right? I'm looking at this from a public health standpoint, not just one patient or two. I'm looking at what does Grenada do to ensure that it captures all the children who have diabetes or who are prone to having diabetes? Or what does it do about its obese young people to make sure that they are not developing diabetes? Those are the things we have to put into coming from the policy, right? The adolescent health policy to make sure that our children are screened early, they know early, and that we educate them. And of course, that we tell them in school what is diabetes things about, so they can understand from small. Girl, boy must know what is things about. And out of us, if there are 100 of us standing here, 13 of us are likely to develop this disease which would make us have a stroke, have a heart attack, lose a foot, have kidney failure. Do you understand what I'm saying? Or go blind. So it's not a question of scaring, it's a question of finding the population, defining the population, then finding the population, and doing what is required, including education. And not only of the people who are probably victims of the disease, but everybody, so that we can all support each other and we can prevent diseases like diabetes happening, happening. Why is it that we asking children to drink water in school? Some parents vex. Oh, when I go to school, it's only water. Sometimes they don't have water in the pipe. No, look, see, rain fall, they don't have water in the pipe. Give the child a bottle of water to carry to school. Okay? Those kind of stuff. I gonna give my child, if I get a child a bottle of sweet drink, nothing wrong with that. Or some lime juice that I make from home. Nothing wrong with that. What I'm gonna the sugar? Those things, it's a bigger thing than just saying, oh, I'm screening. There's a clinic down the road. It has to be with education and people wanting to ensure that they don't have, that they can fight it. They know that they have tools within themselves that they can use to ensure that they don't develop diabetes, that they don't die prematurely from diabetes. Those are the children. Those are the things.
Right. Dr. Fraser, listen to Dr. Nixon, and I'm thinking here, the diabetes story has been around for, a very long time. Of course, in modern medicine and all of that, and advancement in the technology and all of that. We know that diabetes is there. We know it is a serious thing. We've seen, as the folks say, in live and living color, the evidence, what has happened as a result of diabetes. Yet still, the message still doesn't seem to be getting through in a way we would want it to. So much so that people are willing to avoid the highly sweetened drinks and the very sweet foods and all of these things, the high starchy foods. We are not prepared to give it up. And in all fairness, in some instances, maybe there is the economic side of things that we have to consider. But how do we, or what do we need to do? What more do we need to do to get that message out there that, look, diabetes is a very serious health condition that we need to put under control to save our population? Because having diabetes is one thing, but we know of its extensions, so to speak. What more do we need to do to get that message sunk in? Dr. Fraser.
Who, me? Who are you talking to me, Fraser?
Dr. Fraser.
He's talking to me. That's a very important question, right? And it has a lot, of link to it. Because I think most persons in Grenada will have a family, and you said it indirectly. Will have a family, or a neighbor, a cousin, a nanny that would have been affected by diabetes. So as you said, it is seen. One of the roles of, public health, in general, is to meet the people where they are. But sometimes you can do so much, right? Then the next thing, as we had kind of discussed earlier on, if we get outside of the concentration of talking about diabetes in November and spread it out throughout the year, I think that too would assist. Also, we need to sit down, as organization, as a health system or so, and see how we can penetrate more to the population concerning the message, concerning the complications, avoiding, even just living a healthy lifestyle to prevent diabetes and all the other chronic disease involved there. There's a point of, in this day and age, we're an information age, and you can go on YouTube, you can Google, and you will find all the information needed to control and to prevent. But I guess a certain group or a certain agency, or the Diabetes Association, Ministry of Health, or all the stakeholders, we would have to gather all this information and try to bombard the community to see how we can get their attention, right? But even if we do that, you would still find some resistance because of human behavior that I guess Dr. Nixon could expound on that. But again, as you said, the sweetened foods, that this is what we grew up with, adding sugar to tea, the sweetened milk, the soda, the Buster, the Fanta.
Don't call people name, boy. They're going to sue you.
Oh, okay, sorry. It's all great. But so these are the things, sweet to the tongue. So you tell the people, listen, to avoid this, you have to cut the sweet to the tongue are the very nice foods. And it still would be a resistance. Another point, we can collaborate with many different organizations. For example, food and nutrition. They always have healthy foods whereby they can be prepared, it can be economic, and also it can be tasty, because a lot of the time when you go to health fairs, so they all have the displays whereby you have tasty, healthy foods without removing that starvation of that rich, something that you're missing for so long. But it all comes down to discipline, right? We all must be disciplined. And a lot of the time, as human beings, that level of discipline is not there. And if it's not there, we always will fall out through the crack.
Yeah. Dr. Nixon, come in here.
Yeah, I agree with you part of the way, because I'm a public health practitioner, so I cannot see other things. I do agree with you that we have to have integrative practices, but I find that we still don't focus a lot on prevention, and one of the biggest things about prevention is information. We can't keep telling people what to do, right? We can't just keep telling people what to do. Sometimes the information you give is passive information. In Mexico, they can't sell soft drinks in schools. In Mexico, they've banned, and we talk about this every week, they've banned the use of you can't buy ramen. I guess sick. For your children. There are lots of things you cannot do in relation to school nutrition, for example. So you have to start on a multi-level. And yes, you have to start with the individual. What do we do with our children? We need to teach our children what is healthy for them. In 2020, we sat in a consultation to look at childhood obesity. But childhood obesity has to do fundamentally with two things: nutrition and exercise. Can we agree on that?
Yes.
How do we train behaviors for our children and towards our children in relation to their nutrition and the level of activity? We know, and I'm no child, our children or grandchildren, or cousins, sisters, brother, whatever, we know that they're less active than the population was in the 60s. I tell you, I went to Heinz School and I tried to forget where we used to run up and down and play and don't bounce on each other. Running up and down. Once the bell rang, we were outside there running. And you don't see kids doing that because everybody gives their child a handheld device. And it is addictive, especially for the young brain. They get on and they get all this stimulation that they sit and they watch and they watch. Our kids are not as active, okay? Our children don't walk as much. How many children walk to school? Well, they can't walk this week, but how many children walk to school? Walk even short distances. Their parents take them to school. They drive. And yes, it's a sign of development, of betterment. Generally, people are less poor. Well, some, right? But people have more amenities and more conveniences. But unless we can have policy overall that 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 gauge how we provide nutrition for children. How many children you think, hi Dr. Matthias, how many children you think will buy school lunch simply because they think it's poor? The truth is that when a school lunch is prepared, most times it is the nutrition, the nutritious value is considered carefully calculated for the children, depending on what is needed and what is not needed, what is given. Do you remember what you got when you went to the lunchroom in Cuba? We scoffed at it, but it was perfectly balanced meals, right?
But
so how many schools actually prepare proper meals for the children? How many parents will allow the children to buy school lunch? How many parents will give their children, let's say $20? I'm just saying, I don't know what. And the kids keep the money, right? And I had a mother scolding her kid because you was telling her yesterday he was hungry, and she said, I gave you money to buy lunch, but instead you bought junk at school. I see it in your bag. But how many children, how many parents will say, let's work with this. Let's work with what's there. What if the government, through Food and Nutrition, who I know has been working hard to implement a school nutrition policy, how many parents will say, yes, my child should have their lunch in school? How many parents will say, oh, they're going to give lunch in school? What are they giving? Then I'm not giving you any money. Buy lunch in school. No. Who's going to say, no, I don't want this. No, look, come give my children that. My children don't eat this and that. Okay? We have to work collaboratively. We have to include our children, because when we are doing that policy, I can tell you, the children came to the consultation and make us shut up because they knew what the problems were. They know what the problems are. They can tell us, why is it in school it's only sodas in the cafeteria? Why is it in school that they can't get a bottle of water? Why do we have to pay so much for a bottle of water? Okay? Why is it that we can't be guaranteed good water in the pipe? Because we will drink pipe water. Why is it that when we go is only fries and drumsticks? Why is it that there's no salad? Why is it there's no fruit? Why isn't there green bananas and some fish? Do you understand? They knew. Why is it that our school doesn't have place for to run up and down and play? There's no playground. There's nothing like that. Why is it that when I'm in common entrance class, PE gets taken out of my curriculum?
But Dr. Nixon, you mentioned something just now, and I want to take you up on it. And I'm Dr. Matthias has joined us. Dr. Matthias, it's a pleasure to have you. Thank you for joining us. And I have a question that I threw at both Dr. Fraser and Dr. Nixon earlier, and I would be throwing it at you in a while. But Dr. Nixon, you mentioned something earlier that got my attention, as it relates to some of the things that we consume and maybe how we get our children to school. Rather than walking, we drive them. And you mentioned, yes, it could be a sign of development. Now, let us put that in terms of what we consume. Now, as young people, we probably were used to growing up eating green bananas and foods that our parents and grandparents grew, right? Nowadays, let's look at it. If I am able to dip into my pocket, go into the supermarket, and purchase a can of luncheon meat that would probably cost me about $15 or $16, as compared to something that I don't have to pay much for, but is healthier, can we consider that part development? No, my thing here is this a mind thing? Is it something in our mind that has us thinking that way? Thinking that we are maybe, I don't know if you want to call it status or whatever, rather than thinking of our health and what is important. Dr. Mathas, you want to jump in here?
That's a very well. Good night, everyone, and
Good evening.
it's always great to have this discussion on this diabetes month, and to echo Dr. Livingston, it should be done throughout the years. So I'm giving my plug here. Next week I'll be home doing my diabetes clinic and looking forward to see everyone. But getting to your question that you just asked there, is it a mind thing? Do you know you have to look at how we promote food products to our community at large? If I have a corporation and I want to sell that luncheon meat, I will study my population, how to get that luncheon meat to them. And I will develop my algorithm, how to influence that mind. So that whenever you turn that phone on or you look at that computer, luncheon meat will just appear, and it will influence the mind because we all are hacked now. You and I have been hacked. Every emotion that we have, who has that data can influence our choices. But you have to be aware of that. That's where we are in today's environment. And to piggyback on the discussion, in terms of diabetes, we have to understand that diabetes presentation is different to every individual. I never characterize one diabetic person as another. They present differently. And practicing in this field as an endocrinologist approaching 25 years, I could say to you to find out why we cannot reach the individual. It's an uphill struggle. Where are we falling short in our messages? We have to deal with culture. We have to deal with influence, education. All that comes into the equation. Because the first question I ask my patient, are you diabetic? What it is. Let them, so I can know how to approach, my treatment regimen or what treatment to give patients. So diabetes is a complex phenomenon. It's not just like hypertension or it's just like high cholesterol. It's complex. You have to deal with the mind. You have to deal with the level of stress. You have to look at the economic background of the patient. Because there are multiple factors there.
Right. So earlier, I did ask a question to Dr. Fraser and Dr. Nixon. The fact that we hear of diabetes probably every day. We talk it. For example, we're in the program every week. Doctors talk about it. The different organizations speak about it. So we all know that diabetes is present. We know diabetes is dangerous. We know what it can cause. It can end up with kidney problems. You can lose limbs. I mean, so much can happen as a result of that. Yet, the importance of the message can't seem to be sinking in the way we want it to. I want your response. I heard from Dr. Nixon and Dr.
You're
Fraser.
absolutely correct. You're absolutely correct. It's because we have become desensitized. We no longer see diabetes as something urgent. It's part of our culture. Oh, she lost a limb. Oh, she has diabetes. Oh, she had a stroke. That's what it is. You see, when we approach diabetes in terms of an economic, a money thing, when we start having diabetes become a bread and butter on the table to see what it is, that's when individuals will wake up and understand what it is. You see, diabetes starts very silent. If you are diagnosed with diabetes in the early stages now and you're not well controlled, within the next 10 to 15 years, that's when it will manifest its complication. You will not see it early. So it destroys the inside first, then manifests itself outside. So, I have diabetes. I can eat anything. Yes, your vessels are not destroyed yet. But I will say to you, even before, when you start exposing your body to high sugar foods, the process already starts. The inflammation already begins. So we have to show that timeline of what will happen. The message has to change. We have to use, let's say, for example, if I am diabetic, I need to tell the story. I don't need you who don't have diabetes tell the story. You have to get nuance. Find how you can get it on AI. Find how the youth can absorb the information. We cannot use yesterday's way of bringing forth the information to the modern time. So it has to be, everyone has to be on that table and ask the question, not sitting at my conference with my other colleague and say, well, diabetes is 1, 2, 3, these are the symptoms. So what? I pee a lot because I drink a lot of beer. I'm losing weight because I'm doing this or the other. You have to bring it home. You have to tell a personalized story with individuals who have it. Tell your story in your own words, your own narrative, and let it resonate. And that's what I let my diabetic patient do, tell their story. And I, in turn, will share with them, this is what will happen, this is the management, etc. The narrative have to change. It just has to change.
Right. Dr. Nixon, I want to come back to you, and Dr. Fraser, I'm coming to you as well. Dr. Nixon, you mentioned earlier about approaching this thing in a collaborative way. So one, getting the information out there, Dr. Matthias just mentioned, telling the story. What about at the level of policy? You made a reference to Mexico, where, certain things is a no-no. It's not allowed to happen. And I think that's a wonderful, a wonderful way to support, this whole issue. Do we need to do more here in Grenada at the policy level to help support the fight against diabetes?
I think so. I think we need, like I said, we need to implement programs against the mitigators, if you understand. We have to put things into place that keeps the defiance, the obesity and the lack of exercise and the eating the bad food that make people recognize this is not good for me, right? You have to be able to take control of the things that put people at risk. There's some things we can't change. So like I can't change the fact that my mother and father have diabetes, or all my generations have had diabetes, right? But I can change the fact that I eat well at home and that my children eat proper foods and that we're very aware and that we get screened, and that if I already have diabetes, I go and I check my sugars regularly as my doctor asks. I make sure my food is what is required. I make sure I exercise. I'm not asking anybody to exercise like Linda and Victor. No, I'm just asking to go for a walk, to get active, to get less sedentary. And I'm asking to be aware, to know that this is not good for me. I shouldn't have this. Okay? And not saying, well, you have diabetes when I come to your house. Well, she eating that because she have diabetes. We should all be eating healthy. So there's nothing like diabetes food and other people's food. Or the family should be generally eating healthy. So we have to take into consideration that we have to eliminate the factors that can cause us to develop diabetes, or any other disease for that matter. But diabetes, because we're talking about diabetes tonight, and we know what it is. And every individual must recognize his potential. I'm not saying we're going to feed our children with, you're going to lose your eyes and stuff. But we can teach our children how to play for half an hour a day. Make sure that school facilitates. That's policy. School facilitate 30 minutes. World Health Organization asks that our children play for 30 minutes a day, right? World Health Organization asks that we do not give our children sugar sweetened beverages and highly processed food, ultra processed products. Some of them is not even food. What is corn curls? What is ramen? Do you understand what I'm saying? What are the little kiss cake that we eat? That is not food. That is ultra processed product. Fat, highly refined sugars, and then you still put some sweet stuff in the middle of it. Those are the things, right? And help our children to understand that this is not good, because children tell you, we don't want that. I heard kids say, we want it.
I want you to reflect on this one. What's the cost for treating diabetes in Grenada?
What's the cost?
The cost. How much money does the government pay to manage? Then you bring it down. How much does the household? You have to get to those points to develop those policies.
And you're very right, because the policy does include monitoring and evaluation. But I can tell you, the only Caribbean country that has probably done any costing to manage their chronic diseases, and diabetes as one of those is Trinidad. We have not done any research. We don't know what it costs us. We just put in money into it, put in money like you go to a casino, you keep money in there, and you hope you get a good outcome or some outcome. See ladies with a little cup of money and they put in a machine and they pull this thing and they put the money in the machine and they pull it down. That's how we're doing. We keep taking care of it while we're there. We do what we have to be, what we think has to be done, right? Because we already have victims. We keep forgetting in the line there are those people who need to be helped, who need to be taught, and those who we already still have in a state of wellness that we can preserve. We don't do that.
Because to answer the question that was asked here about policy, the only way we can have policies regarding to diabetes care are what's the hours lost with individuals who have diabetes. Let's say you may have a job, and if the sugars drop that day or it's very high, you can't go to work. What the productivity is, there is a cost for that. There is a cost for the complication of diabetes, kidney failure. How much does it cost the government? Amputation. Think about the cost of that. So those are when we get those numbers and we see what those numbers are, then the policy will say, well, we are spending, let's say, half of our healthcare budget on diabetes and its complications.
And that is why a lot of my focus is on prevention. I focus a lot on prevention because I think in some situations the horse really just gone through the gate, and because our attitude or history of health behaviors, there's some people that we really can't help, right? I think we have a responsibility to preserve our young population. As you and I won't get any money from NIS.
Dr. Fraser, I want to bring in Dr. Fraser here because there's something very interesting inside of there that I'm picking up. And Dr. Matthias mentioned the cost and all of that is involved. There's another twist to this, right? And I'm bringing it back on the actual patients because I think I've seen it. And I've heard people spoken about it. For example, people who are hypertensive, right? So you have medication. You take your pressure tabs and it's going to help bring your blood pressure down. But you ain't stopping drink because you have medication. How does that fit into diabetes? So you have your medication that would help regulate your insulin or whatever it is. And so because you have that available to you, then you don't think it is important to reduce on the amount of sugar that you use or the amount of starch or whatever because you have your medication to take to keep it under control. Dr. Fraser?
Right. So that's a very important phenomenon, right? So as you guys know from before that, I'm a person living with diabetes. It's probably just over 22 years. So when we have to educate, ourselves or population about managing or living with diabetes, you have to take that multi-sectoral or that multi-pillar approach. So medication is one, you have exercise is one, you have diet is one, you have psychosocial, right? So when we have to establish that if generally one of the pillars are not taken into consideration, is like it's not going to have the effect, and a lot of the times we say, oh well, yeah, I'm gonna habit. And then what happens is that we do it every day, and that's a normal thing. So the pressure remains high, or the glucose is always high because you're breaking the dietary rules that you should follow, or you're not exercising, but you're trying to counteracted with high dose of medication, which doesn't do anything. I think education is very important to actually counteract that. And another thing, yes, after education, is the individual to actually pull themselves together and to make that special effort, because a lot of time it's not easy. Yeah.
Where are you, Godfrey?
I think
I want to make a point in relation to the education thing.
Mhm.
So I want to draw on the experiences we had with vaccines and the naysayers. We know that before the development of insulin, or people died from diabetes, right, Dr. Matthias? We
Right.
know that the oral medications that are presently available, and constantly there's a lot of research and development of new medications, and we see preservation of life. However, there are other modalities of treatment, but there are a group of people like the naysayers among the vaccine, the anti-vaxxers and stuff, who will tell you not to take your medication because it's going to do X, Y, Z. And so what happened, our diabetics and people with other diseases, but I want to, since we focus on people with diabetes, are given multiple, there are multiple sources of information that creates confusion and creates a lot of non-adherence to the medications from the doctor. Well, Miss Jane tell me if I drink Christophine water, my sugar go away, go heal. Or Mr. John say if I drink whatever, my sugar is going to go away, right? And often when people are lured, I'm saying it for want of a better word, are lured into alternative therapies, and I'm not saying that some of them do not work. I'm saying that people are often lured and do not have any, because many other people who do, many of the people who do the other therapies are not, don't have a place to go to be followed up, because they feel, since you're not making me drink Christophine water, and please people don't drink Christophine water, that's just an example, right? Since my doctor wouldn't approve, or my doctor is not who told me I must drink Christophine water, I will do this on my own. They don't follow up their sugars, they don't follow up their general physical well-being, and they get left out there, okay? Because we tend to take a lot of information from naysayers or people who have alternative therapies who don't do the actual management of the patients, and that is a big problem.
Dr. Matthias, I want you to, you were coming in. So,
What is very important here, and that question you asked is very important, because many patients would assume I'm prescribed certain pills, certain insulin, therefore I can continue my lifestyle. That tells me that the patient has not been empowered about the condition. The patient has not understand what diabetes, that condition, is all about. So then I will put the onus on we physician, the care providers, that someone comes to me from diabetes care. Let's talk about diabetes, what it is, what our expectation, what the goals are. So if you improve your blood sugars, the present regimen may have to change. I always tell my patients, let's put a goal. Within the next 3-4 visits, we got to start decreasing medication, because you are going to change your lifestyle. You are going to eat less carbs, more protein, you're going to exercise, etc. And let's look at that. I'm not going to say see you in 6. Patient is prescribed medication, but they're doing the same thing. I will say that patient was not informed, they didn't have a diabetes class, and they didn't have a nutritional class, and that's why they're doing that same thing.
But Dr. Matthias, isn't it also because we don't have a standard of practice? We don't have a guide.
Well,
we don't have,
yes, we don't have we don't have a guide. But the physician himself, who has been trained, has been taught with that. You know, there's some tough patients out there, because they will come with things from the internet. They will come with their natural herbs. And I say, okay, you wish to do it naturally, why not? Check your blood sugars before you take that product. check your blood sugars 2 hours after the product. See if there's any change in blood sugar. Educate me. I am willing to. I don't tell them no. Because remember, I was not trained in the natural products.
Well,
You
I
know,
will
I
tell you
was,
that as well.
you
But
know,
what I'm trying to tell is that we don't have a standard. So if I were a diabetic, or if I were a patient who went to Dwight Mathias because of my diabetes, right? Dwight Mathias would manage me different, maybe from Livy Fraser, maybe from Sonia Nixon, maybe from somebody else, because we don't have standards, we don't have guidelines as to how. We don't have a program where patients can go and get properly educated. We don't have it.
very, good. Excellent. Now, look at the small island of Grenada. Look at the rich sources of physicians we have on that island. Trained in Cuba, trained in England, maybe trained in Canada, trained in the USA, trained in the West Indies. What are the guidelines for all those different training environments? It may differ somehow. That's why collectively we need to get at that table and discuss, all right, what are the objectives? What are we trying to accomplish? How should we, so we have to get together because we have different training environments. And it will be an uphill struggle because Dr. X was trained in that area and Dr. Y was trained in that area. He comes with a different protocol. And you could see, and the patient, oh, I don't like Dr. X, I'm going to go to Dr. Y. Dr. Y gave him different information. And they say, well, Dr. Y, X told me this. And the patient is confused. So yes, we need a standard protocol. I come down and I give my lectures and I always say up front, this is the protocol that is used in these United States, et cetera, or internationally. So that's a major problem. Why you are not seeing, based on the question you asked, the patient has not changed. Because Dr. Y said, oh, and Dr. X said, oh, and you see that.
So can I just come in?
Yeah, sure.
I think one of the initiatives that the Grenada Diabetes Association, I think the Ministry of Health, Chronic Disease, they wanted to start, like a diabetes school or something like that, which after a person, especially is newly diagnosed, or let's say a person that's been living with diabetes for over a long period of time, they kind of lost their way. Kind of get them back in group. I think we started a discussion and then it just kind of fell through the crack. But I think that could be a tool to actually start. So you have the diabetes school, you do like a week of classes, then you have all the different aspects, which involve education, because it's important as physicians that we educate, sit down and talk with our patients. Dr. Sonia, you always say, but this, for example, those in the hospital, for example, being diagnosed in the hospital, not saying that us physicians in the hospital don't do what we have to do, but then sometimes you have a lot of patients, so sometimes the time you would try to probably sit down and to give a nice, good, session, or, so that you could educate your patient. You may not have, you might cut it a bit shorter than usual because you have 20, 40 other patients to see within a specific, you understand? But so coming back to that initiative, so I think the diabetes school will be probably a start. And then that discussion what Dr. Mathias mentioned about us physicians coming together and, formalizing something standardized. And it's not just for diabetes, it's for a lot of other conditions, chronic disease and so forth, so that we can have, Grenada is relatively a small country. So I think...
The challenge I have here, and I hear you talk, you're probably talking about the CDSMP, right? Where patients are taught to manage themselves and all the rest of it. Hear me?
Yeah.
What's my challenge? That we seem to exist in, you mentioned it as outside. I'm not outside. I might have a private practice, but I practice with we only have 110,000 people, right? And why is it that the doctors in the community are not equally involved in, are not equally trained in whatever system. Because I know that CARFA and who have systems like the Hearts Initiative and the whole diabetes plan. Why is it that I'm not part of that program? Or Dr. John, who's down the street from me, or Dr. Thomas, who's in a different place? Why aren't we all part? Why isn't there integrative and general preparation of professionals who deliver care, right? Why is it that I send all my patients, all my diabetics to nutrition counseling, but other people don't do it, right? So we have the first thing, we have a system that's fractured for whatever reason, subjectively, I think, right? Because the private practitioners, you have to invest. Private practitioners, oh, we're going to make money when you teach them. Yes, we're going to make money. Guess what? We're also going to have more time to sit with patients. Also, we're going to be able to prevent patients from coming to the hospital. So you shouldn't have 30 patients in your clinic. You should not, especially when we have primary care centers, because we basically do primary care, right? We should be able, all of us, to have the same guidelines, have the same knowledge. If PAHO says, let's go this way, Grenada is going that way. I am not whatever any other country. Why am I not involved in the training that says, here is the protocol, here is what the research shows that does best for us, here is what you're going to do that. So if my patient has been get on XYZ, what is my next move? Okay? Because we as physicians and general caregivers also need to be trained. We need to have knowledge. We need to have knowledge that is shared among all of us. How many people, general practitioners, make sure that they, with on diagnosis, the patients go to the dentist, they go to the podiatrist, they go to the eye doctor, they go to the nutritionist. They make sure they have material for testing their sugar regularly, and they understand that in the first one, this is how we're going to go. Not everybody manages that, and that is part of having a good protocol, management protocol. But we have to have integrative care, which means primary care, private care, secondary care, whatever, right? Must all have the same guidelines for managing the one disease that is killing off so many of us.
I'm listening to you all, and something keeps resonating that Dr. Matthias mentioned earlier, and I'm wondering here if at the administrative level, and I'm making that distinction here, administrative and medical, and I'm wondering if at the administrative level there is a serious misunderstanding of what Dr. Matthias mentioned as it relates to what is it costing us as a country to deal with this issue. Because I'm listening here, and one doctor, you talking about having 30 patients in a clinic and all of that, and it's worrying. It is worrying, and because we're getting we're almost out of time, Dr. Matthias. I think you should be with us next week. I hope.
Yes, we will be. Yes.
Definitely. I want us to seriously to continue this discussion, because I want us to look seriously at the cost. We may not be able to put some figures, but to sort of explain what is involved as it relates to what is it costing the country. I think
it should be a little more than that, because I think it should not just be financial costs. It must be consequences, which includes
of course,
loss, quality of life, all of those things. So we could look at consequences.
Definitely, because I mentioned that. I mentioned cost because you're getting to realize that, for example, you listen to discussions at the administrative level, and you hear a lot about addressing health problems, and Dr. Nixon, I know you're heavy on prevention, and this is something you don't hear about at all at that level. So, and I think I mentioned last week, you hear about having health insurance. You hear about improving the services at our hospitals and all of these things. But we do not hear a lot about teaching our people how to prevent themselves from getting there. And I think we need to look at this. And if we understand, again, the cost involved, it probably may change the mindset of the discussion. So I
want to make a political point here, and I saw your political.
We need to make it quick because I want us to continue because we're almost out of time. Yes,
and I'll tell you why I want to make this point because I think it's very important, and there are probably a lot of people looking at this program. So, and it was mentioned in the beginning about the screening and the health center and the health fairs, the myriad of health fairs that we have. A health fair is supposed to be an environment where people get information about disease management, prevention and management. A lot of people use a health fair as a clinic. And that's one of the things I think we need to teach our population, that a health fair is where you go. Yes, you can get screened for disease, but if you already have diabetes, you shouldn't be coming there to check your sugar. You should be checking your sugar at home or when you go to your clinic. But a health fair should be developed around giving people education on the disease problems that we have, how to prevent and how to manage and how to take care of yourself. And I wish, it is my dream, because if we were to look at the amount of people who go to health fairs, it's probably more than half of the population at the end of the year, and we get nowhere because there are people who go to every health fair. So if I have a health fair in my community, John from our next community would probably come, and then I might have the joy of Dr. Matthias bringing on some foreign drugs, right? And Dr. Matthias brings his foreign drugs, and they're distributed. But patients can and they come and they have a health center, they give them some medications. When it comes to management of conditions, people go from one health fair to the other, which is really an unfair situation. You should go there and sit and talk and gather information about nutrition, about exercise, about taking care of your foot, taking care of your eyes. That is what a health fair is supposed to do. Keep on enhancing, keep on reminding people of how do I stay well? Yes, I can screen, but how do I stay well? And our population needs to understand the concept of wellness, because you can have diabetes and be well. You can have hypertension and be well. You can have had a stroke and be well. We need to emphasize that to our population instead of just saying, oh, this medication, that medication, because you have to look across the board at how do I prevent this, how do I treat it, and how am I improving? Are my outcomes better? We have to look along the whole span of our diseases, and we're not doing that. We're not doing that, and we're losing as a result of that. And what Dr. Matthias has said in relation to how do you get your patient to walk his path on disease is an individual thing. People have to have that opportunity to be able to discuss what their situations are. And we have not written that yet into our treatment plan, to our management plan of not just diabetes, but all of chronic disease.
Okay. Thank you very much, Dr. Nixon. So Dr. Fraser, you can take a minute, and then Dr. Matthias would have the last word as we wrap. But we'll definitely continue that discussion next week. So, Dr. Fraser, your final words.
So it is evident that diabetes affects Grenada. It's something that, as a people, as a health system, we ought to address. I think it's something preventative level from all levels, preventing the onset of any chronic disease or any other situation, preventing, even if it's already onset, preventing complications, right? And furthermore, preventing death and the affection of the quality of life of persons. I say this month, November the 14th, was World Diabetes Day, right? Coming from the body of Mr. Frederick Banton, one of the person that identified the DNA composition of insulin, right? And it's celebrated every year. And the motive is to always raise awareness. And between 2024 to 2026, one of the main promotion that we like to do is be the well-being of a person, including mental health and physical health of each individual. And I hope and I pray as persons living with diabetes or persons that are affected somewhat, we can be well. All right, we can be well.
Thank you very much, Dr. Fraser. Dr. Matthias, you have the last word.
Thank you, thank you. As usual, this discussion is always interesting, and I do hope that those who are participating on the different platforms are generating questions and shooting it out. But I must say, when we look at diabetes, we should not look at it within one silo. What is the relationship with diabetes, and how do you define that diabetes with cancer? Is there a relationship? Is there a relationship with diabetes and depression? Is there a relationship with diabetes? You just named the condition. Is there a relation with diabetes with certain medication? So we should look at diabetes holistically and very individual. And I do hope our discussion will continue as we gather data. We need data about the diabetes on our island. So as a means to know where the cost is. Is diabetes higher in St. Andrews compared to St. George's? Is diabetes greater in what age group? Who diabetic patients are having the amputation? Is the amputation related to diabetes or other traumatic injury? Is the dialysis related to hypertension or diabetes? You know, we need to know the impact of this disease on our population so that we can make some strategic moves and develop policies to help improve our diabetic care.
Thank you very much, Dr. Matthias. Dr. Nixon, thank you very much. Dr. Fraser, thank you so very much to our viewers and our listeners. We thank you very much for staying with us. But please do join us next Tuesday. We will continue that discussion as we delve deeper into diabetes. Yeah? So thank you very much once again, and do have a good night. All the best.
Broadcast.